As Jenny has said, my name is Alex Lesokhin. I'm an oncologist at Memorial Sloan Kettering. I really am looking forward to speaking to everyone here today on the topic of BCMA and other targets in myeloma. I want to highlight first that, there's been a ton of progress in myeloma therapy over the years. And one can see that as each new class of drugs has gotten to be approved, survival times for our patients continue to increase and improve, which is really a fantastic thing. So I think there's a lot of room for optimism in our field. Now, I want to focus specifically on monoclonal antibodies because a lot of the targets are derived and the drugs are derived from monoclonal antibody-based technology. And I'm going to spend a little bit of time sort of reviewing that. So as you may know, monoclonal antibodies are antibodies that are generated in a laboratory, but are derived from natural antibodies that people have, right? And so we can generate antibodies in the lab to any specific target because they have this variable region, and typically IgG class antibodies have two variable regions that are directed at a target antigen, and then they have this common region, what's called the FC region, which is the effector arm. And so naked antibodies, as I would call things like daratumumab, isatuximab, elotuzumab, these are antibodies that work by recruiting natural immune effector cells and natural immune effector mechanisms listed here. Now, antibodies can also be generated with a payload or a drug target, antibody-drug conjugates. And this would work where the antigen provides the specificity, if you will, sort of like a UPS address or a mail address to the myeloma cell. And then when the antibody binds, it is internalized, and inside the cell, there's an acidification process that happens. The toxin is released, it kills the cell. Now, as I mentioned, there are multiple specificities that can be delivered by one antibody. And so you can have target antigen 1, you can have target antigen 2. And of course, you can engineer this in many different ways, making it look like a molecule or like an antibody molecule, or like these other funky looking things here. These are called bispecific engagers. And the concept here is, again, you bind through this variable region your target antigen on the myeloma cell, and then you recruit another cell specifically, for example, a T cell, which is a kind of immune cell that's very important in cancer control. And you activate that T cell, or here an NK cell. And in both cases, then this leads to a secretion of or release of various mediators that lead to myeloma cell death. Now, finally, monoclonal antibodies provide that same platform, and these variable regions provide the mechanism by which a CAR T cell therapy derives its specificity. Here, this target antigen is combined with natural T cell receptor machinery. So a T cell, again, normally has a receptor which sees an antigen presented in a specific context. It's called an MHC molecule. And then when that is presented, that leads to an activation signal delivered through CD3. And this also requires a second signal, a co-stimulatory signal. The prototypical signal is CD28. There's other options as well, of course. And then a CAR T cell, then it fuses the intracellular signaling machinery to provide the signal where the specificity is derived by this antibody target. Now, more modern CAR Ts, the ones that are one that, for example, that was recently FDA approved, use a different signaling moiety for 1BB, co-stimulatory moiety. Now, because antibodies can be generated in the laboratory against a variety of specificities, then the question is what are the best targets for this? And so there's been a variety of targets that have been investigated, and a lot of these with really phenomenal clinical efficacy. For example, CD38 targeted by daratumumab and isatuximab. SLAMF7, the target of elotuzumab, and now emerging target BCMA, as well as other novel targets like GPRC5D and FCRH5. And I'm going to spend the rest of the time talking about these specific targets and what's going on there. So I'll start with BCMA. So this is B-cell maturation antigen. It's so B cells actually are developed from a sort of stem cell and then go through a development pathway. And then the BCMA molecule is actually expressed on terminally and long-lived plasma cells. It's actually required for long-lived plasma cells. And here I'm just showing you a schematic of the molecule. It has an extracellular and an intracellular signaling domain that provides, when it's triggered, survival signals for long-lived plasma cells. And I'm just going to point out that the location is here on chromosome 16, and that's relevant for some resistance work that is emerging, resistance to therapy work. So I'm just going to talk a little bit more about some of the signaling here. So BCMA, again, is on terminally differentiated plasma cells and on myeloma cells. I just wanted to point out that its main ligand here is this molecule called APRIL, but it can also be triggered by other molecules like BAFF. And the BAFF is relevant for normal B cell, earlier B cell development, but there may be some overlap there. And similarly, plasma cells can develop in the absence of BCMA, although long-lived plasma cells do require BCMA. But there is this other molecule that can be triggered by both APRIL and BAFF, and there's this sort of complex overlap in this system, where one may imagine that plasma cells, although really depend on BCMA, they may also survive with tachy signaling, at least malignant plasma cells, or other signaling derived from other receptors as well. The other thing that's sort of interesting about this molecule is that it can be cleaved, the receptor, and become a soluble BCMA. And this serves sort of as a normal physiological, kind of regulatory mechanism, because soluble BCMA would bind up these ligands and limit signaling. And so it's sort of like this feedback loop that can occur there. But this is also emerging as a therapeutic target because if you inhibit this molecule with an inhibitor, you can increase surface BCMA expression. And so one can imagine loss of BCMA expression when you're targeting it as a mechanism of resistance. This may, by cleavage and using a gamma secretase inhibitor, you might increase its expression. And you can see here that obviously would decrease soluble BCMA. This is looking at laboratory systems in a petri dish with cell culture. Now, BCMA can be targeted therapeutically. And what are the therapies available here? Now, I'm going to present a series of slides here that have a ton of information. And I think these will be available to you later to review in greater detail. But I'm just going to point out the highlights. So one is that antibody drug conjugates targeting BCMA, one of them has been FDA approved, and this is belantamab mafodotin. It has about a third of people treated every 3 weeks intravenously, and the heavily pretreated patients can respond, and response can be quite durable with this therapy. It does have an eye side effect and a mandated REMS program requiring ophthalmology evaluations with every dose, which is a potential challenge of this therapy. Nevertheless, it is available and off the shelf. Now, this year at the annual American Society of Hematology meeting, it seemed was a BCMA bispecific year. And so these are all the bispecific BCMA CD3, so T cell engaging and BCMA engaging bispecific antibodies for which data is now available. And these are all in heavily pretreated patients. And what one can see, numbers still are small, but what one can see is highly, highly encouraging in that when higher dose levels are achieved and the therapeutic doses are achieved with these molecules, the response rates tend to be between 60 and 80%. Now, these are T cell engaging therapies, and when you activate T cells, then T cells will secrete cytokines and inflammatory markers. And this is a phenomenon known as cytokine release syndrome, which for patients is experienced as a high fever, malaise, fatigue, loss of appetite, perhaps, for the most part. In some cases, it can be more severe, though, where blood pressure drops and maybe oxygen level drops, and this requires ICU level care. Although this may be alarming sounding, I would say that algorithms for treating this unknown side effect are fairly well developed at this point. And for the most part, this can be controlled and reversed rather quickly without detrimental effects on the therapeutic outcome. Now, there are also, of course, BCMA CAR T cells, and there are many different constructs here showing various types of the variable regions that are used to confer the specificity to BCMA, as well as the co-stimulatory domains, the various trial numbers that were used to study them, and the mechanisms used to get these constructs into individuals' T cells. I'm going to focus on just one of them, really, Idacel, which was just FDA approved like literally 2 weeks ago, which is very exciting. Although I would point out that there is a CAR T construct developed by Legend Biopharma, and that's now being co-developed with Janssen through the CARTITUDE program that also is showing encouraging data and moving pretty quickly through the development pathways. So here is the idacaptogene visleucel data, or Idacel. This was FDA approved just this past month. And what this shows is in a heavily pretreated patient population, especially at the higher dose levels, there's a median progression-free survival of 12 months. And among individuals that respond very deeply, there is a 20-month progression-free survival. Now, for heavily pretreated patients without other options, a one-and-done therapy that results in a 1-year progression-free survival is really quite encouraging. Of course, there's room for improvement here, and additional research to that end is occurring. Now, as you can see, there are many BCMA-directed therapies. So can you sequence the therapies? Well, this is actually an area of active study. So here, Adam Cohen and I presented a couple of cases early on, and this is actually a patient that I treated. He actually delivered the CAR T at UPenn, and the patient, you can see, responded with a minor drop in M spike, a more significant drop in light chain. Unfortunately, this was a partial response in this case, so the patient progressed within a couple of months. And then we had access to the belantamab mafodotin in the context of a phase 1 study. And again, the patient responded after a few doses. There needed to be a treatment delay because she developed the eye toxicity called keratopathy. And then with dose reduction and treatment delay, unfortunately, she ultimately progressed. Now, what's interesting here is that after CAR T cell therapy, the plasma cells still express BCMA, shown here in red. And after this antibody drug conjugate, again, the plasma cells still express BCMA. So this sort of leads to the question of, well, what are the mechanisms of resistance here? So BCMA loss seems to be an obvious mechanism of resistance, and it has been reported, and I'm showing this here, but it's not actually that common. So, but anyway, here, this is a mechanism by which it can occur. Here, in this case, this patient was treated with CAR T, and you can see some extramedullary disease on imaging here. The patient responded, this goes away, and then it reappears, and that's the M spike is shown here. And what you can see is that there is complete loss of BCMA expression, looking at RNA level expression here at relapse, and you don't see it when you try to stain for it in the bone marrow sample. These investigators sequenced the sample, and through very high depth sequencing, they could then look at what's going on chromosome 16, where this BCMA locus is. And what they can see is here there's complete loss of expression of BCMA, or loss of copy number, essentially loss of this part of the chromosome. So genetic loss of BCMA. Now, this isn't actually the most common mechanism of resistance. I think a more common, what we think is a more common issue that leads to resistance is actually the T cell phenotypes of the patients. And what this group of investigators was able to show us is that individuals with more central memory type T cells and a higher CD4 to CD8 ratio was more likely to respond to treatment, whereas those that had terminally exhausted T cells, the ones that express sort of like things that you may have heard about, like PD-1 and LAG-3, other things that are targeted for immunotherapy, not in myeloma, but in other cancer types, as well as high regulatory T cells. These individuals were more resistant to therapy. So, of course, additional research is being done to try to mitigate some of these resistance mechanisms. But in terms of addressing what can we do in terms of individuals that lose BCMA expression, either through genetic means or through increased shedding of the target through gamma secretase activity. So one could think about focusing on non-BCMA targets. So I'm going to just briefly mention GPRC5D. So this is expressed very highly in myeloma and not really expressed anywhere else, just in the bone marrow. This is a screen of all normal tissues. It's a little bit in the skin. Here, this is a complicated slide, but what this is really looking at by using a fluorescently labeled molecule, a group of molecules, a red one for BCMA and a blue one for GPRC5D, and looking at a merge that looks green under the microscope, and then counting what cells express what you can see is that some cells have a lot of just GPRC5D, some have a lot of BCMA, many have both, but if you're able to target both targets at once, then you probably knock out the majority of CD138 positive myeloma cells. And this is shown in a sort of a laboratory model or a mouse model where if you generate a CAR T for BCMA or for this target GPRC5D, and then you have a tumor system where you have cells that express just the GPRC5D as well as cells that express both targets, and then you treat them. So you can treat them with an irrelevant construct, a construct against BCMA, and then after an interval, you can treat again with a construct against BCMA, a construct against GPRC5D, and what you see is really when you sequence both, that's when you get the complete response. When you just give BCMA, you don't, because these non-BCMA expressing cells lead to escape, here shown in this bright color. What about other targets? So FcRH5, this one is expressed on chromosome 1, and I highlight that because a lot of myeloma patients have excess chromosome 1. So this target is expressed on myeloma cells, not really expressed in normal tissues, a little bit in the spleen, where one might see terminally differentiated B cells as well. So these targets are also being targeted. So I'm happy to say that we have a GPRC5D directed CAR T cell therapy that's undergoing dose escalation now. I think we've treated about 10 patients on this study, and Sham Malankody is the PI at our place investigating this. And there have been bispecific antibodies targeting both GPRC5D or FcRH5, and some data was reported for these at ASH this past year. And again, one can see, and these trials allowed prior BCMA exposed individuals. What one can see is that you do have pretty meaningful responses, particularly when higher doses or high effective doses of these agents were achieved. So in summary, BCMA, as Jenny said, is an excellent target for myeloma therapy. There are now 2 FDA-approved therapies available, which is really, really exciting. Genetic deletion can be a mechanism of resistance. Receptor cleavage by gamma secretase can also reduce the density of the receptor and potentially result in resistance. But I think immunophenotype, at least with CAR T and BiTE therapy, seems to be more of a important way or target for further research to try to improve the outcomes. Alternative therapies that target GPRC5D and FcRH5 appear to be really, really promising and continue to undergo development. And I think with that, I'd like to thank you for your attention, and I have my information there should you have any questions.